UGCR on topic vertigo. Today is a great learning treat for all of us as we also have an international speaker program on vertigo. To begin with, we start with UGCR, and before I start, I'd like to invite Dr. Malika Gupta to brief us on topic vertigo.
Good afternoon all. I'll be briefing you about the topic vertigo. So vertigo is an illusory sense of motion or spinning sensation which can be internal, or the patient can feel that the objects in the surrounding are moving or tilting. This can be linear, rotatory, or change in orientation relative to the vertical direction. Many a times we confuse vertigo with dizziness. So to clarify, vertigo is a type of dizziness that feels as if you or your surroundings are spinning, whereas dizziness is a range of sensations including feeling lightheaded, faint, giddy, unsteady, off balance, or weak. There are two main causes of vertigo, which include peripheral or central vestibular disturbances, out of which peripheral vestibular disturbances account for 90% of the causes of vertigo. Nystagmus is a classical sign of vertigo, and the management modalities of vertigo include pharmacological and rehabilitative methods. Now, I would like to invite our first presenter from the Department of Anatomy to continue the presentation.
A very warm good afternoon to the respected dignitaries, esteemed faculty members, and my fellow peers. I, Gauri Sharma from MBBS first year, am here with my team of Anushka Singh, Chanchal Sirvi, Palak Garg, Suhani Mittal to represent for the 6th undergraduate combined round on the topic vertigo from the Anatomy Department. Under the guidance of Dr. Jagmohan Sharma, Professor and Head of the Department of Anatomy, and moderated by Dr. Pankaj Kumar Singh, Professor of the Anatomy Department. Before starting with the anatomy of the internal ear, let us acquaint ourselves with the anatomy of the ear and the different parts of the ear. The ear is the organ for hearing and is responsible for maintaining the balance and the equilibrium of the body. The ear is composed of three parts: the external ear, the middle ear, and the internal ear. The external ear is composed of the pinna, also known as the auricle, and is responsible for collecting the sound waves from the surrounding medium to transmit into the external acoustic meatus. The external acoustic meatus is an S-shaped tunnel which is divided into two parts, the cartilaginous part and the bony part. The cartilaginous part is represented by the outer one-third of the external acoustic meatus, while the bony part is represented by the inner two-thirds of the external acoustic meatus. The tympanic membrane is the partition between the external acoustic meatus and the middle ear, and it is composed of three layers: an outer cuticular layer, a middle fibrous layer, and an inner mucous layer. Leading into the middle ear, which is an air-filled cavity situated between the external and the middle ear, it consists of three auditory ossicles: the malleus, the incus, and the stapes. Now, the function of these auditory ossicles is to increase the frequency of the sound waves without raising the amplitude. A focused image of the middle ear tells us about the roofs possessed by the middle ear. The roof, also known as the tegmental wall, the floor or the jugular wall, the medial wall, also known as the labyrinthine wall, the posterior wall, the anterior or the carotid wall, and lastly the lateral wall, which is also known as the membranous wall. Now, the medial wall of the middle ear consists of some important structures, which is the promontory formed by the basal turn of the cochlea, the lateral semicircular canal below which lies the facial canal, and the fenestra vestibuli, which leads to the opening of the vestibule. Now, starting with the main topic of today's discussion, which is the internal ear, also known as the labyrinthine. Now, the labyrinthine is a Greek word meaning a complicated or irregular network of passages or paths in which it is difficult to find one's way, or a maze. The internal ear is an intercommunicative system of membranous sacs and ducts and is situated in the petrous part of the temporal bone deep to the tympanic cavity. It is filled with a fluid called the perilymph. It consists of two parts, an outer bony labyrinth and an inner membranous labyrinth. The bony labyrinth. The bony labyrinth is an intercommunicating system of bony cavities It is filled with a fluid called the perilymph and consists of the following parts: the cochlea, the vestibule, and the 3 semicircular canals. The cochlea. The cochlea is a bony canal which roughly resembles the shell of a snail. Its apex is directed laterally towards the medial wall of the tympanic cavity, while the base of the cochlea is directed towards the bottom of the internal acoustic meatus. If we take the cross-section of a cochlea, we come across 2 structures, which is the modulus and the cochlear canal. The structure of modulus is quite similar to that of a screw. The base of the modulus can be represented by the head of the nail, which lies at the fundus of the internal acoustic meatus. The apex of the modulus is directed towards the middle ear and is overlaid by the apical turn of the cochlear canal. The cochlear canal spirals around the modulus and takes 2 3/4 turns. From the surface of the modulus, there is a structure called the spiral lamina, which projects into the cochlear canal and divides the cochlear canal into 3 sections: an upper scala vestibuli, lower scala tympani, and between these two, the scala media, also known as the cochlear duct. Now, the scala vestibuli is separated from the cochlear duct by the Reisner's or the vestibular membrane, while the scala tympani and the cochlear duct are separated by the basilar membrane. At the basal turn of the cochlea, the scala tympani presents 2 features: the fenestra cochlea and the cochlear aqueduct. The fenestra cochlea leads into the tympanic cavity below and behind the promontory, while the cochlear duct lets the perilymph of the cochlea to communicate with the cerebrospinal fluid of the subarachnoid space. The vestibule. The vestibule is a central ovoid cavity in the bony labyrinth and has the following 4 walls: the anterior vestibular wall, the posterior vestibular wall, the medial vestibular wall, and the lateral vestibular wall. The anterior vestibular wall communicates with the scala vestibuli of the internal ear, while the posterior wall bears 5 openings of the 3 semicircular canals. The medial vestibular wall possesses 2 recesses: the elliptical recess behind and the spherical recess in the front. Both these recesses are separated by a structure called the vestibular crest, which splits inferiorly to enclose the cochlear recess. The spherical recess lodges the saccule and is perforated by the foramina for the transmission of the lower division of the vestibular nerve, while the elliptical recess lodges the utricle and is perforated by the foramina for the transmission of the upper division of the vestibular nerve. Coming to the semicircular canals, the bony labyrinth consists of 3 semicircular canals: the anterior or the superior semicircular canal, the posterior semicircular canal, and the lateral semicircular canal. All these semicircular canals lie at right angles to each other, and one end of each semicircular canal is dilated to form the ampulla. The anterior semicircular canal lies in the vertical plane at a right angle to the long axis of the petrous temporal. Its ampulated end communicates with the vestibule. The posterior semicircular canal also lies in the vertical plane, parallel to the long axis of the petrous temporal. Its ampulated end communicates with the vestibule. The non-ampulated end of the anterior semicircular canal and the non-ampulated end of the posterior semicircular canal form the cross commune and enter into the vestibule. The lateral semicircular canal lies in the horizontal plane, and both the ends of the lateral semicircular canal enter into the vestibule. I hope you're all ears to what I'm saying. Coming to the membranous labyrinth. Now, the membranous labyrinth is an intercommunicating system of membranous sacs and ducts, which lie within the bony labyrinth and is filled with a fluid called the endolymph. It consists of the following parts: the cochlear duct within the cochlea, the saccule and the utricle within the bony vestibule, and the 3 semicircular ducts within their respective semicircular canals. The cochlear duct. The cochlear duct is the anterior spiral portion of the membranous labyrinth. It lies within the bony cochlea and is situated between the scala vestibuli above and the scala tympani below. On the basilar membrane of the cochlear duct, there is a structure called the spiral organ of Corti, which is the sensory organ for hearing. The spiral organ of Corti possesses the following parts: The tunnel of corti, which is composed of the outer and inner rod cells and is filled with a fluid called the corticolymph. The hair cells, which are of two types, the inner and the outer hair cells. The supporting cells, the dieters and the Hensen's hair cells. And lastly, the membrana tectoria. The saccule and the utricle. The saccule and the utricle are membranous sacs that lie within the bony labyrinth. The saccule is connected to the utricle by the utricosaccular duct, the vertical limb of which continues as the ductus endolymphaticus, and its end is dilated to form the saccus endolymphaticus. The semicircular ducts. The semicircular ducts are located within the bony semicircular canals. The ampullated end of the semicircular ducts contains a sensory organ called the crista ampullaris, which is responsible for the kinetic balance of the body. While the saccule and the utricle present in the bony vestibule possess the maculae, which is responsible for maintaining the static balance of the body. Here is a table summarizing all the sensory receptors of the ear present in different parts of the membranous labyrinth. The cochlear duct, present within the bony cochlea, possesses the spiral organ of corti, which is responsible for hearing. The saccule and the utricle, present within the bony vestibule, possesses the macula, which maintains the static balance of the body. Lastly, the semicircular duct, present within the semicircular canals, which possesses the crista ampullaris, responsible for maintaining the kinetic balance of the body. Now I would like to invite my fellow colleague from the Department of Physiology to continue the presentation.
Before we proceed further, I'd like to extend a very warm welcome to our guest faculty for the day, Dr. Philip Rajan Devasahayam and Dr. Anita Bandhari. I now invite our speaker from Physiology to continue further.
Good afternoon to all the dignitaries, esteemed faculty members, and my fellow colleagues present here. Today, under the expert guidance of Dr. Aparna Garg ma'am, Professor and Head of Department of Physiology, and under the excellent moderatorship of Dr. Sabir Hussain sir and Dr. Malika Gupta sir, I, Ekta Arora, along with Gauri Sharma, Priyanshi Singh, Siya Maheshwari, and Shaurya Lekhra would like to present on the topic Physiology of Equilibrium. If I asked you to list your senses, you would probably mention things like vision or taste or sound. But it turns out that we can actually detect a lot more than that. One sense that is really important but not often thought about is our sense of balance. Equilibrium refers to maintaining the line of gravity at constant, at rest, or during movement by adjusting tone of different muscles. Equilibrium is of two types, static and dynamic. Static equilibrium refers to the maintenance of body posture at rest or in response to linear acceleration or retardation, whereas dynamic equilibrium refers to the maintenance of body posture in response to rotational acceleration or retardation. The vestibular apparatus is the sensory organ responsible for detecting sensations of equilibrium. The vestibular apparatus is mainly composed of two otolith organs and three semicircular canals. The two otolith organs are the utricle and the saccule. On the inner surface of the utricle and saccule is present a little sensory area known as the macula. The three semicircular canals, namely the anterior canal, the posterior canal and the lateral canal, are all arranged at right angles to each other, thus representing all three planes in which our head can rotate in. The semicircular canals are filled with a fluid known as the endolymph. One end of each semicircular canal is dilated and is known as the ampulla. The ampulla contains the sensory organ for the semicircular canal known as the crista ampullaris. On top of the crista ampullaris is present a loose gelatinous tissue mass known as the cupula. The receptor cells of the vestibular apparatus are known as hair cells. The hair cells of the utricle and saccule are present in the macula. The macula consists of a otolith membrane which contains several tiny calcium carbonate crystals known as the otoconia. These otoconia in some cases might displace from their original position and can freely flow in the inner ear. This is known as benign paroxysmal positional vertigo. The hair cells in the utricle are placed in a horizontal orientation, whereas the hair cells in the saccule are oriented in vertical direction. The hair cells of the semicircular canals are present in the cristancularis. Hair cells are of two types, type 1 and type 2. Type 1 hair cells are flash-shaped and make synaptic contacts with afferent nerve fibers only, whereas type 2 hair cells are cylindrical in shape and make synaptic contacts with both afferent and efferent nerve fibers. On the apex of each hair cells are present 50 to 70 small motile cilia known as the stereocilia. At the end of each stereocilia is present a large non-motile cilium known as the kinocilia. The hair cells are polarized cells with a membrane potential of about -60 millivolt. When the stereocilia are bent towards the kinocilium, the cell depolarizes. That is, potassium ions are released from the leaky channels, which opens the voltage-gated channels, releasing calcium ions. The release of the calcium ions stimulates the release of neurotransmitters such as the aspartate and the glutamate, and thus the cell depolarizes, in which the membrane potential increases. When the stereocilia are bent away from the kinocilium, the hair cells are hyperpolarized, that is, the membrane potential decreases. The changes in the activity of the hair cells are conveyed to the central nervous system by the vestibular part of the vestibulocochlear nerve. Linear acceleration is detected by the saccule and the utricle. Movement caused in the otolith membrane caused by linear acceleration causes the otoconia to shift and thus hair cells bend. Depending on whether the stereocilia bend towards or away from the hairs from the kinocilium, the cell depolarizes or hyperpolarizes. For example, when a person moving in a car is suddenly thrust forward, the otoconia falls backward, resulting a state of disequilibrium, and the person leans backward until the otoconia returns back to its original position and the nervous system senses a state of proper equilibrium, and the person no longer leans backward. The movement in the endolymph caused by angular acceleration is detected by the cristancularis, present in the semicircular canals. The movement in the endolymph causes the cupula to move in the opposite direction of the head movement, which in turn bends the hair cell. Depending on whether the stereocilia bend towards or away from the kinocilium, the hair cells depolarizes or hyperpolarizes. For example, a movement to the right stimulates the hair cells present in the right lateral canal, whereas they inhibit the hair cells present in the left lateral canal. In the right lateral canal, the endolymph and the cupula is pushed towards the ampulla, causing the hair cells in the right canal to be depolarized. The exact opposite of this occurs in the left lateral canal, where the cell hyperpolarizes. The sensations of the linear acceleration and angular acceleration from the hair cells of the utricle, saccule, and the semicircular canals are conveyed to the vestibular ganglion, or also known as the Starbuck ganglion, from which the vestibular division of the 8th cranial nerve takes the stimulus to the vestibular nuclei. The vestibular nuclei is composed of 4 subnuclei, namely the superior, medial, inferior, and lateral nuclei. The neural signals from the vestibular nuclei make several important connections, such as descending connections, which are taken to the spinal cord through the vestibulospinal tract, which are involved in the vestibulospinal reflex, in which alpha motor neurons stimulate the muscles and thus maintains body posture. Some of the impulses are sent to the cerebellum via the vestibulocerebral fibers, and this involves the vestibulocerebral reflex. Impulses from the superior and the medial subnuclei are taken through the medial longitudinal fasciculus to the oculomotor, trochlear, and abducent cranial nerve nuclei, which stimulates the eye muscles. This is known as the vestibulo-ocular reflex. When the head is rotated in the left direction, the eyes move towards the left direction in order to maintain focus at a specific point. For example, in this case, when the head is rotated in the right side, the hair cells in the left lateral canal are depolarized, and the hair cells present in the right lateral canal are hyperpolarized. The stimulation from the left lateral canal through the medial longitudinal fasciculus is taken to the oculomotor nuclei, stimulating the lateral recti of the contralateral side and the medial rectus of the ipsilateral side, and making the eyeball to move towards left. A quick summary. The sensations of the angular acceleration, linear acceleration, and keeping the head upright are sensed by the semicircular canals, saccule and the utricle. The impulses are then taken to the central nervous system, which sends the impulse to the spinal cord and the eye muscles, controlling eye and oculomotor muscles and the muscles of the body, thus maintaining body posture and the balance of the body. Now, I would like to call my fellow colleague from the Department of Pharmacology to continue the presentation.
Good afternoon, esteemed dignitaries, respected faculty, and my fellow colleagues. My name is Aditya Bainsla, and today I will be representing the Department of Pharmacology and presenting on the topic of the pharmacological management of vertigo. This presentation was prepared with the help of my teammates, Aman Chaudhary, Diya Balwara, Diya Sethi, and Mansi Mehra, under the guidance of Dr. Anusha Vora ma'am, Professor and Head of Pharmacology, with the moderation of Dr. Anurag Pathak sir, Associate Professor of Pharmacology. In this presentation, we will be examining the treatment of the following three conditions: vertigo, nausea and vomiting, as well as compensation. First, taking a look at the neurochemistry associated with vestibular transmission, we can see that the neurotransmitters glutamate and acetylcholine act as excitatory in both peripheral and central roles, while dopamine acts as excitatory in only a central role. GABA is an inhibitory neurotransmitter in the central capacity, while histamine and noradrenaline both have unclear and modular roles respectively. Taking a look at the drugs used in treatment of vertigo, there are four major classes: vestibular suppressants, antiemetics, miscellaneous drugs, as well as agents of uncertain efficacy and mechanism. Taking a look at vestibular suppressants in a little more detail, anticholinergic drugs act on the M3 and the M5 receptors. Their primary side effects are dry mouth, dilated pupils, decreased alertness, sedation, confusion, loss of sweating, blurry vision, urinary hesitancy, and constipation. For the treatment of vertigo, only central anticholinergic drugs are used. A primary example of these would be scopolamine, while the drug that is currently under development is zamifenicin. Antihistaminics, which are H1 receptor blockers, are also used to treat vertigo. These side effects are sedation and weight gain, alongside all the aforementioned side effects of anticholinergic drugs. These drugs are, however, preferred over anticholinergics because they have less severe side effects. For the treatment of vertigo, only the first generation are used, such as meclizine, diphenhydramate, cyclizine, promethazine, and diphenhydramine. Benzodiazepines are GABA agonists, which reduce the nystagmus and nausea that are derived from peripheral vertigo. The side effects include sedation and addiction, which is why they are prescribed in controlled use. They also may inhibit the compensation property of the body. Examples of benzodiazepines are diazepam, lorazepam, and clonazepam. Calcium channel blockers are used to treat dizziness and prevent the influx of calcium from the endolymph to the cells of the cristantularis. The side effects include weight gain and drowsiness, and this is also contraindicated in pregnancy. Examples include senalizine, flunarizine, nimodipine, and veramapil. Taking a look at the antiemetics class, includes antihistamines, which we discussed earlier, such as meclizine, sphenothiazines, such as promethazine, which we already discussed, as well as prochlorperazine, with the side effects of dystonia and decreased vestibular compensation. Prokinetics, such as domperidone and metoclopramide, are also used and also contain the same side effect of decreased vestibular compensation. 5-HT3 or serotonin antagonists are also given, such as ondansetron and granisetron, but these are not that useful in motion sickness. Taking a look at the mechanism of the antiemetic drugs, there are four major pathways that are involved in the vomiting center of the brain, which is present in the medulla. The higher cortical centers, which include pain, repulsive sites, smells, and emotional factors, are acted upon by antihistamines. The vestibular nuclei, which take in the input from the labyrinth, are acted upon by hyoscine or M1 receptors. The chemoreceptor trigger zone, which is the main site for sensing emetic stimuli, is acted upon by phenothiazines, domperidone, metoclopramide, granisetron, ondansetron, palonosetron, as well as vagal efferents, which convey the signals from the gut to the brainstem, are derived from enterochromaffin cells, which are acted upon by nabilone, metoclopramide, granisetron, ondansetron, and apripant. Taking a look at beta-histine, it is a histamine analog which acts as an analog at the H1 receptor and an antagonist at the H3 receptor. It facilitates vestibular compensation and is especially useful in Meniere's disease for symptomatic relief, as it also increases labyrinthine blood flow. The major routes of drug administration are transdermal patches of scopolamine, sublingual administration of lorazepam, and in case of nausea, in mild nausea, we administer drugs orally. In case of gastric atony or vomiting, these drugs are administered suppositorily. And in cases of emergency, all these drugs are administered injectably. In conclusion, as we've seen, there are a vast amount of drugs that can be used to treat vertigo, encompassing various categories. So there's always an opportunity to explore different avenues of treatment for each individual patient. Also to be noted is that vestibular sedatives should not be used for more than 4 days, as it interferes with the body's natural compensatory mechanism. I would now like to invite my colleague from the Ophthalmology department to continue the presentation.
Good afternoon to one and all present over here. Today, I, Anjali Bulchandani, along with my group mates Hemang Kapoor, Chitra Ichlal, Tabassum Khan and Lakshya Srivastava, is going to talk about nystagmus on behalf of Department of Ophthalmology under the guidance of Dr. Chaitanya Gupta sir, Professor and Head, Dr. Jaya Devendra ma'am, Professor, and Dr. Krishna Shah, Associated Professor. So basically, what is nystagmus? Nystagmus is defined as the regular and rhythmic to and fro involuntary oscillating movement of the eye. It is due to the disturbance or abnormality in any one of the factors responsible to regulate normal ocular position and movement. The factors responsible are sensory visual pathway, vestibular apparatus, and midbrain and cerebellum. And then we talk about the classification of nystagmus. It constitutes a physiological nystagmus and a pathological nystagmus. In physiological nystagmus, we have optokinetic nystagmus. It is a jerk nystagmus induced by presenting to gaze the object moving serially in one direction of gaze, such as strips of a spinning optokinetic drum. Like you can see an optokinetic drum in this image, and the nystagmus induced by it. This is the nystagmus which is induced. Then we have endpoint nystagmus. It is a fine jerk horizontal nystagmus seen in normal persons on extreme right and extreme left gaze. Like when we move the eye in extreme right gaze, the nystagmus is induced in the left direction, but when we move the eye in extreme left gaze, the nystagmus is induced in the right direction. Then we have physiological vestibular nystagmus. It is a jerk nystagmus which can be elicited by stimulating the tympanic membrane with hot or cold water. It is based on caloric test. When we stimulate the tympanic membrane with hot water, the direction of nystagmus is in the same direction, but when we stimulate it with cold water, the direction of nystagmus is in the opposite direction. Then we have pathological nystagmus, in which we have nystagmus due to disorders of visual function. It may occur due to any disorder which is affecting any part of the visual system from retina to visual cortex. Then we have vestibular nystagmus, in which we have peripheral vestibular nystagmus. It is associated with destructive lesions of vestibular systems such as labyrinthitis, vestibular neuritis, and BPPV, that is benign paroxysmal positional vertigo. It has a slow component which is away from the visual target, and a fast, quick corrective component which brings the eye towards the visual target. Then we have central vestibular nystagmus. It has a beat nystagmus. In primary position of gaze, the direction of nystagmus is always in the upward direction. It is seen in lesions of brainstem. Then we have downbeat nystagmus. In primary position of gaze, the movement of nystagmus is always in the downward direction. It is seen in lesions of brainstem and cerebellum diseases. Then we have seesaw nystagmus, in which one eye moves in upward direction with intorsion and the other eye moves in downward direction with extorsion. It is associated with upper brainstem lesions. Then we have features of nystagmus, in which we have waveform. It constitutes pendular and jerk nystagmus. In pendular nystagmus, we have equal velocity in each direction of gaze. And in jerk nystagmus, it has a slow component in one direction and the fast component in other direction. The direction of nystagmus is defined by the fast component. Then we have conjugacy, in which we have conjugate nystagmus, which is symmetrical in both the eyes in all directions of gaze. Then we have disconjugate nystagmus, which is asymmetrical with respect to direction and frequency in both eyes. Then we have dissociative nystagmus, which is asymmetrical but unidirectional. Then we have types of nystagmus, in which we have manifest and latent nystagmus. Manifest nystagmus is present all the time, but latest nystagmus will be shown only when one eye is covered. Then we have directions of nystagmus that I'll show you by the video. So we have different directions of nystagmus, in which we have torsional nystagmus. It has both vertical and a diagonal component. It is most commonly present in posterior semicircular canal BPPV. Then we have horizontal nystagmus, in which the nystagmus moves only in the horizontal plane. It is present in lateral semicircular canal BPPV. Then we have vertical nystagmus. The nystagmus moves only in the vertical plane, and we see it in superior semicircular canal BPPV. Then we have right and the left nystagmus, depending upon the direction of fast component, like you can see. Then we have fast and slow nystagmus, which can be pendular or jerk nystagmus. Then we have a nystagmus which can be classified on the basis of gravity, which is away from the cavity or towards the cavity. Now I would like to hand over the mic to my colleagues from the Department of ENT. Thank you.
A very good afternoon to all the respected dignitaries, esteemed guests and my fellow friends. Today, I, Malika Gupta of 3rd year MBBS Part 2 is here to present on the topic VERTIGO from the Department of ENT and Head and Neck Surgery under the guidance of Dr. Arora Sir, Head of Department, and under moderatorship of Dr. Priyanshi Gupta Ma'am and Dr. Malika Gupta Ma'am with my colleagues Shant Gupta, Aditya Bainsla, Bhavya Mahatma and Chahat Agarwal. Today we shall be discussing on all these topics. We shall learn how to identify a case of vertigo, whether it is central or peripheral in origin, is it the inner ear problem, the etiology behind it, the diagnosis and its management. At some point of time or the other, we all have experienced an episode of dizziness. But we need to know was actually due to vertigo or simply due to lightheadedness, that is transiently slowed consciousness, faintness can progress to loss of consciousness, or due to disequilibrium, that is difficulty in maintaining the balance, or due to oscillopsia, that is movement or oscillation of the visual surroundings, or due to vertigo, that is illusion of motion while stationary. What is vertigo? Vertigo is basically a symptom depicting an underlying pathology and is not a diagnosis. Many of us have experienced a transient feeling of dizziness and perception of ourselves or the environment spinning around us after rapidly turning in circles. Associated symptoms with the vertigo include problems focusing the eyes, hearing loss in one or both the ears, loss of balance, ringing in the ears, nausea and vomiting. There are certain red flag indicators which prompt an urgent referral to a specialist. These include sudden, new unilateral development or progression of hearing loss, incapacitating dizziness for more than 6 weeks, severe tinnitus, any neurological symptoms or signs, discharging ears, ear pain, and progressive unsteadiness or falls. As we all know that a detailed history forms the backbone of any diagnosis. Therefore, emphasis should be made on history, history, and history. This is an example of a performer that we fill for a vertigo patient in our institutions. Now let's learn how to evaluate a dizzy patient. For it, we need the complete description of the dizziness. We need to note whether it is episodic or continuous in nature, the duration of the individual attack, whether it lasts for a few seconds, minutes, hours, days, or continue for months. Effect of the head movements. Then we need to note, are there any specific positions that induce vertigo? Is there any preceding history of trauma? Or if the patient is on any previous medications like for infections, hypertension, diabetes, cardiac arrhythmias, or CNS disorders? Are there any psychogenic disorders associated like the anxiety and panic disorders? Or presence of any triggering events like the stimuli due to sound, pressure, or movements. We also need to check for associated or the concomitant symptoms like the ear symptoms, the discharge, pain, hearing loss, tinnitus, ear fullness, the eye symptoms like the diplopia and the vision loss, headache, or those associated with CNS like the paralysis, parathesias, dysarthria, dysphagia. This is an algorithm which helps us to distinguish between true vertigo and dizziness, and if true, then to differentiate between central vestibular dysfunction and the peripheral vestibular dysfunction. The etiologies for the central vestibular dysfunction would be further discussed in detail by my fellow mate from the General Medicine Department, While if it is of peripheral variety, then the causes may include BPPV, labyrinthitis, Meniere's disease, acoustic neuroma, ototoxicity, otitis media, and the temporal bone fractures. Now, let's see how to differentiate clinically between peripheral vertigo and central vertigo. The nystagmus is of combined type, that is both the horizontal and the torsional variety. It is in one direction. It is inhibited on visual fixation. It is fatigable and latency is present in the peripheral variety, whereas it is in the central vertigo. It is purely vertical. It may change the direction. No change on optic fixation, and fatigability and latency are absent. The patient may present with imbalance that is mild to moderate, but he is able to walk. Nausea and vomiting are usually present and are severe. Hearing loss is common and neurological symptoms are absent in the peripheral variety, whereas the patient may experience severe imbalance and would be unstable to stand or walk. Nausea and vomiting varies. Hearing loss is relatively rare and neurological symptoms are common in the central variety. The recovery begins within days in the peripheral vertigo, whereas it is slow with central vertigo. The head thrust sign is present in peripheral and it is absent in the central vertigo. The common causes of the peripheral vertigo includes BPPV, vestibular neuritis, Meniere's disease, trauma to the labyrinth, infections and drugs, whereas those of the central vertigo are migraine, vertebrobasilar insufficiency, cerebrovascular accidents, multiple sclerosis, brain tumors. Now, let's see what different differentials can be made for a patient presenting with the peripheral vertigo. BPPV, Meniere's disease and vestibular neuronitis, these three are the most common that we see clinically. The other differentials that can be made include perilymphatic fistula, vestibular congestion, acoustic neuroma and labyrinthitis. The above three we shall be discussing in detail in the upcoming slides. Vestibular concussions, it is characterized by the persistent vertigo. It lasts for months to years. Perilymphatic fistula is characterized by intermittent vertigo and is brought on by Valsalva. Acoustic neuroma is characterized by persistent mild vertigo associated with unilateral hearing loss, and the MRI is suggestive of mass lesions. Labyrinthitis is characterized by severe acute attack of vertigo associated with sudden hearing loss, tinnitus, and associated with nausea and vomiting. 90% of the cases of the peripheral vertigo that present to us in the OPDs are mainly due to BPPV. So let's see what BPPV is. It is characterized by vertigo when the head is placed in a certain critical position. No hearing loss or other neurological symptoms are associated with it. Positional testing establishes the diagnosis and helps us to differentiate it from the positional vertigo of central origin. It is basically caused by a disorder of the semicircular canal. The most common being involved is the posterior semicircular canal, followed by the lateral semicircular canal, then followed by the anterior. The pathophysiology behind it is basically that the otoconal debris that consists of crystals of calcium carbonate, it is released from the degenerating macula of the utricle and it floats freely in the endolymph. Now, when it settles on the cupula of the posterior semicircular canal in a critical head position, it causes the displacement of the cupula and ultimately leads to vertigo. The diagnosis can be made on the basis of the Dix-Hallpike test and the management can be done by the Eccles maneuver. Now we shall learn how the Dix-Hallpike maneuver is performed. The Dix-Hallpike maneuver is performed when it is suspected that BPPV is the cause of causing the dizziness in the patient. The head is rotated to 45 degrees to the affected side and the patient is asked to lie down such that the head is extended to about 20 to 30 degrees. If BPPV is present, then the nystagmus will occur. The rotational eye twitching is known as the torsional nystagmus. The sideways eye twitching is known as the horizontal nystagmus. The upside down eye twitching is the vertical nystagmus. Then the same procedure is repeated for the other side, on the opposite side, as seen in the video. Now, if torsional nystagmus is present, it is suggestive of posterior canal BPPV. If horizontal nystagmus is present, it is suggestive of lateral canal BPPV. If vertical nystagmus is present, it is suggestive of superior canal BPPV. Now let's learn how we perform the Eccles maneuver. Eccles maneuver is performed to treat the posterior semicircular canal BPPV by repositioning the otolith back into the macule of the utricle and the sacule. The patient is asked to rotate the head to 45 degrees in the affected side and is asked to lie down such that the head is extended to about 20 to 30 degrees. If BPPV is present, then the nystagmus will occur. Wait for 30 to 60 seconds till the vertigo or the nystagmus disappears. Then the patient is rotated to 90 degrees and is held in position for 30 to 60 seconds such that the affected ear faces upside. The patient is further rotated to 90 degrees and hold in position for 30 to 60 seconds, and the head should form an angle of 45 degrees with the horizontal. Some another person can help with these positions while performing the maneuver. Then the patient is asked to sit down and the chin is brought down to 20 degrees. Meniere's disease. It is a disorder of the inner ear where the endolymphatic system is distended with the endolymph. It is characterized by vertigo, fluctuating hearing loss, tinnitus, and the sense of pressure in the involved ear. The pathophysiology behind it is that the distension of the cochlear duct, scala media, and the sacule, and to a lesser extent the utricle and the semicircular canals. It is basically either due to the overproduction or the underabsorption of the endolymph. Vertigo is sudden in onset and lasts for a few minutes to 24 hours. Tinnitus is low-pitched roaring type. Investigations include PTA, speech audiometry, caloric test, and the Gleason test. Management depends whether the attack is acute or of chronic phase. If it is acute, then simply we reassure the patient, we go for a low salt diet, vestibular sedatives, IV fluids, and electrolytes. For chronic phase, we give vestibular sedatives, vasodilators, and diuretics. Vestibular neuronitis. It is characterized by severe vertigo of sudden onset with no cochlear symptoms. Attacks may last for a few days to 2 to 3 weeks. It is thought to occur due to a virus that attacks the vestibular ganglion. Management is similar to that in the Meniere's. The treatment is non-specific and includes hospitalization and IV fluids, diazepam, promethazine. Few other causes include labyrinthitis, vestibulotoxic drugs, head trauma, and acoustic neuroma. Then there are certain vestibular function tests which could be performed. These are of two types, the clinical test or the laboratory test. The clinical test includes the spontaneous nystagmus, fistula test, Romberg's test, gait, past pointing and falling, the Dix-Hallpike maneuver, and the test of cerebellar dysfunction. The laboratory test includes the caloric test, electronystagmography, optokinetic test, rotation test, and the posturography. Then how to manage the patient of vertigo? It's simply due to treating the cause that leads to the vertigo, so we go for a centric management. To manage an acute episode, we give vestibular sedatives. Thank you. Now, I would like to call my fellow from the Department of General Medicine to continue the presentation.
Good afternoon to all the respectable dignities and my dear colleagues. Today I, Gauri Sharma, with my batchmates Vedangi Sekra, Garima Chaudhary, Malika Meena and Arya Jain are here to present a PPT on the topic Central Vertigo under the guidance of Dr. Puneet Rajwani, Professor and Head Department of General Medicine, and moderators Dr. Shrikant Chaudhary and Dr. Varun Bhargav. In the following slides, we are going to discuss introduction, causes, history taking, clinical features, tests, investigations, and treatment of central vertigo. Starting with the introduction, the central lesions causing vertigo typically involve vestibular pathways in the brainstem or cerebellum. This may be due to discrete lesions such as from ischemic or hemorrhagic stroke, demyelination or tumors, or they may be due to neurodegenerative conditions that include the vestibular cerebellum. Subacute cerebellar degenerations may be due to immune or including paraneoplastic processes. Now coming on to the causes of central vertigo, cranial nerve deficits suggest involvement of the brainstem or cerebellum. Caudal cerebellar infarction leads to damage to the brainstem, hence signals cannot pass on further. Posterior fossa hemorrhages, cerebrovascular diseases, basal artery occlusion and vertebral artery occlusion leads to less blood supply. Vertebral artery dissection and neoplastic causes are as follows. chronic myeloid leukemia, primary CNS lymphoma, paraneoplastic syndrome, vestibular schwannoma, temporal bone metastasis, and lastly, vascular and ischemic stroke causes are as follows: ischemic stroke and posterior fossa hemorrhages. Multiple sclerosis, autoimmune allergic causes are as follows: anti-GQ1B antibody syndrome, Behçet's disease, antiphospholipid syndrome, and Cogan syndrome. The following points are needed to keep in mind while taking the history of the patient who presents with a complaint of vertigo. Whether this was the first attack or not, the duration of attacks, the provoking factors, the laterality of the vertigo, whether it is unilateral or bilateral, onset, whether it was acute or chronic in onset, progressiveness, and any associated oral symptoms like hearing loss, otalgia, or earfulness. Double vision and numbness are also checked. Clinical features which are associated with central vertigo are as follows: headache, nystagmus, diplopia and vision loss, visual distortion, tinnitus, earfulness, depressed consciousness, sweating, palpitations, dysarthria, dysphagia, nausea and vomiting, ataxia, postural instability, paralysis and paresthesia. The following tests are conducted for diagnosing vertigo. Caloric tests. The main aim is to induce nystagmus by thermal stimulation of the vestibular system. We also check for labyrinthine origin of vertigo. Fistula test. The nystagmus is produced by change in the pressure in external auditory canal, which is transmitted to labyrinth. EAC pressure is increased by intermittent tragal pressure or sacralization. Both of these tests are useful in peripheral vertigo. Head impulse, nystagmus, and skew deviation, also known as Hind's test, is the best test to differentiate between central and peripheral vertigo. This test is valid if the patient is still suffering from ongoing continuous vertigo. The investigations carried out for central vertigo are as follows: Hind's test, caloric test, fistula test, magnetic resonance imaging, magnetic resonance angiography. In case of peripheral vertigo, the head impulse test is abnormal, corrective saccade to the midline with rotation of head, whereas in central vertigo it is normal, no corrective saccade is seen. The nystagmus in peripheral vertigo is unidirectional and horizontal, whereas in central vertigo it is horizontal and direction changing, vertical and torsional. There is no skew deviation in peripheral vertigo, whereas there is skew deviation present in cases of central vertigo. Then we come on to the treatment, and the basis of the treatment is treating the underlying cause. The patient counseling is very important, visual feedback training and vestibular rehabilitation is advised. The treatment of underlying causes can be performed as follows: multiple sclerosis. In multiple sclerosis, corticosteroids are used to decrease the inflammation during relapses. In cerebrovascular diseases, thrombolytic medications like alteplase are given. Proprioceptive neuromuscular facilitation and core strengthening exercises are advised. In paraneoplastic syndromes, chemotherapy and immunotherapy is advised. The following drugs are given. Antihistaminics like meclizine, dimenhydrinate, and promethazine are suggested, but they are not suggested for a longer period of time as they dampen the compensatory mechanism of the body. Benzodiazepines like diazepam and clonazepam are suggested. Anticholinergic drugs like scopolamine, transdermal patch is given. Physical therapy like repositioning maneuvers and vestibular rehabilitation is advised to the patient. Though all these drugs are mainly useful in treating peripheral vertigo, but they do not play much role in treating of central vertigo. Thank you everyone.